First of all, we need to find a consensus amongst the rhinologic experts on the positioning of biological treatment, because biological treatments are novel, are effective, but at this moment are not always available and are still very expensive. Therefore, we should not consider positioning biological treatment or endotype-driven treatment at first-line medical care. This should also not be positioned at second-line medical care, but should be considered now, and especially even more in the future, at tertiary care level, where we see patients that are uncontrolled despite currently available medical treatment or despite 1, 2 or more sinus surgery interventions.
Biological treatment at this moment has been tested mainly in chronic sinusitis with nasal polyps, and I think this is also the right place to have them. Right now we have been testing mepolizumab, rezlizumab, which are both anti-IL-5 treatments, omalizumab, which is anti-IgE, dupilumab, which is an anti-IL-4, IL-13 receptor antagonist. These treatments are mainly tested, as I said before, in chronic sinusitis with nasal polyps, but I think they are especially of interest in those patients with nasal polyps and asthma. Why? Because those patients have the more severe disease, and we see the highest number of recurrences in those diseases. We see that over 12 years, 80% of the patients, the polyps will recur. That doesn't mean per se that you need a reoperation. But what it means is that in half of those patients, so in 36% of the whole group, you will need a revision surgery. And in this group, especially the ones where you need revision surgery all the time, you can end up in your life with like 5 to 10 sinus surgeries. And I think this group, where you have a high recurrency rate and where you need a lot of surgery, is a group which is not under control with the classic medication. That is really the group where we need the biologicals.